Next, we have Dr. Anand Parthasarathy with us with his cases.
Am I audible?
Yes.
Thank you so much for inviting me. I must thank the Anand team of consultants and fellows and Rohit for giving such fantastic organization and hospitality. Though I did like Manish's photographs, I think Dr. Gettinel's photographs seem to be the best. He seems to have the best looking female colleagues in all his photographs.
I love the keratocole. You know, the eye rubbing bird should be renamed keratocole or keratocole. No, it's a poor joke. Okay.
Okay. Okay. I just got a couple of presentations, and we'll see. Since this is the last presentation, we'll see how we could probably try and finish this faster. Nothing new in terms of where I use my intacs. Our results have been quite good, and we've seen this earlier in terms of having good results post intacs. On an average, our spherical equivalent does come down by about 4 diopters. This is just to show that when you can also do TopoLink PRK for a lot of earlier cones, and some of them do improve quite dramatically with a good improvement in the both the pre and post topographies. They look actually quite nice, can be improved with a contact lens. Now 1 year results of PRK have been very good as well, topo guided. But when you're actually combining two different technologies, you got intacs, which is basically sometimes unpredictable, and you've got an excimer in a keratoconic cornea post CXL. You're trying to combine two different technologies. So it was definitely a challenge when one of these patients who came. There have been 3-step procedures described in literature who just modify the way of doing intacs, topo guided PRK and CXL. Now this is the first patient, a 23-year-old medical student. We did do intacs and CXL first because that was a protocol almost about 4 or 5 years back. 1 year later he finishes MBBS and is going to the UK for further specialization. He's seeking more clarity of vision. He does have some glare and halos, but he wants to do it before he goes to the UK, since he's not very sure he'll get an English speaking doctor in the UK. This was of course before Brexit. This was something like what we got. You could make out the fairly good placement of cones on both sides. And he's got definitely some improvement in the topographies. This is the pre-op, and we did do the planning, and Gitansha went over it quite in detail, so I wouldn't touch upon that, just to show you that a lot of these patients can still be improved with a bit of planning, and you do include the subjective refraction. You can convert a slightly irregular cornea to something as regular as this, and he does well just with a pair of good glasses. You look at the eye trace. This is for both the eyes. We follow the same procedure. This is pre and post. A slight improvement in the glare and the halos, which you basically attribute to higher order astigmatism. Just to show you the eyes, this is one other patient. You can actually convert something as irregular as this to something almost like a normal topography. One other patient more severe in the left eye, over a period of about 3 to 6 months, still fairly regular. These patients do, it's not that you can bring it down to 0 in terms of symptoms, but they do see better with a pair of good glasses. This is just to show that they do have good vision. So in a post intact corneas, you have very limited options. You can give them glasses, contact lenses, but I do find if you regularize the cornea and then either give them a glass or a contact lens, they do quite better. Topography, guided ablation and PTK combined do give good uncorrected, best corrected visions. There is also an option of maybe doing non-custom PRK, and though I have very small numbers, that's an option, and of course planning is required. Before I go to the case, any comments from Dr. Damien, Cordelia? Okay. This is one other Malaysian student from Kuala Lumpur, consulted in Malaysia and Singapore for his keratoconus. He is an Indian origin student. he wants to study to become an engineer. He comes back, we did a DALC for him, and this is post suture removal, 0.5 with about 3.5 cell, left eye post collagen cross linking, and we were planning for a toric ICL for the left. The suture related, even if you do a perfect suture, you can get sometimes irregular corneas and asymmetric astigmatism, and in these patients you can give them glasses but they are never very sharp. So we did the same process of doing a topo guided PRK post graft. I find that a lot more predictable than compared to doing it for keratoconus. This is the ablation pattern. As you can make out, it is not a typical cylinder cone. You do put in the planning for the high order abrasions, and this is the ablation pattern that you get. This is pre and post. You can make out that the irregular asymmetries definitely come down a bit, and when you compare the different maps, he's actually definitely better. So this is pre and post, and you can make out the steeper parts of the cornea is a lot more flatter in terms of the asymmetries come down. So post DALC implantation, post DALC options of visual improvement do include topo guided PRK. I think that would be my last slide. Thank you so much, and it's been a pleasure being here.